I am just going to speak on iCube technology, that means innovative IT approach for the integrated mosquito management. And we are the actually I can say pioneers in this field. For the past 12 to 13 years we are working on the how best we can mitigate the mosquito-borne diseases through simple IT technologies. Because mosquito control program is being tackled for several centuries actually by chemical control, biological control, mechanical control and other biophysical control, but not through IT in principle, that is the one. So we started looking into how best we can use the simplest model for the complex problem. This is a simple definition, and in 20 minutes time I will just go through. I don't want to go through this is the Indian health sector industry, 65 billion as of now. It is going up to the 100 billions. And ICT communications, though they have a specific budget allocated for this, we are all talking about the only post-mortem cases, not before that. That means hospital management, radiology informatics, blood bank information system. These are all the things. Once the disease is transmitted, then only you are taking care of all those things. Prior to that, there is a one step on which we work actually. That means prevention. 2012-13 budgets also in the National Rural Health Mission, they have allocated $4.414 billion, and also they are going to start this year National Urban Health Mission. And you see, as I explained to you, existing IT solutions you see in any Indian health sector, there will not be any kind of advanced forecasting system or any preventive measures. Only once the disease is transmitted, only hospital management information system. This is mostly confined to the corporate sector. Hospital management system is for the corporate sector where they wanted to identify the patient ID, so all those things and all. Laboratory information system, this is another one including health as well as analytical. Radiology information system, only to see the images of the things they will put in the archives. Whenever the patient comes after 3 months, you get back that one and see this one and take one more image and then see the comparative analysis. But really what this IT is doing, it is not up to the expected mark. Blood bank information system, okay, this is also same story. Major challenges actually for IT transformation in the health sector was huge amount of data. Indian data is rich actually, we are rich to the power of n number, but little information is known about it, but no knowledge to representation. You go to NVPDCP, National Vector-Borne Disease Control Program, 100 years of malaria data is there. What we have achieved for the past 50 years. Similarly, poor adaptation of health officials to the reluctant, or they don't want to move from the traditional to the modern system. You ask any health officials or deputy director to use the existing developed database of malaria system for the effective report generation system, 80% people will never do that. We have got all our own system, we don't want. Not much importance is given for the quick communications like outbreak information system, most important. Outreach program, these two are absolutely de-linked actually from the communications. That is why outbreaks are recurring and occurring every year or every alternate 6 months. Practically no ready-made solutions are available on advanced forecasting to predict the outbreak of the diseases which need to be looked into very seriously by the government. So what we have done, of course, India is very rich in innovation, but it is a fragmented innovation. We don't know what things are going on in Hyderabad, parallel we don't know what things are going on in Lucknow. Limitations in sharing the data due to several factors, including insecurity. I don't want to give my data, what I have collected in the Northeast region, because you may get one more authorship in the paper, or you may steal my patent. All useless things are there. That is why sharing of data is not there. That is why it is lying and dying. Many hurdles from innovation to implementation, major hurdles. Major setback is ego. That means no IT person is interested to work with biologists. I am basically a medical entomology product of WHO organization. And then I started learning ABCD from the computers without any, that once this particular component is there, every interdisciplinary science will be out. So now, about India, of course, I don't want to go to the details. This is a life expectancy 62/64 for male, 62/64 female. And healthy, there is a difference between these two. Life expectancy is different from the healthy life expectancy. So probability of dying under the age group of 5 is 1000, of course, 76 per 1000. Probability of dying under the 15 to 16, okay, expenditure on his meager amount, expenditure on health sector. You see, this is the three-tier system actually in the Indian primary PHC, secondary called private clinics, tertiary is the private including corporate hospitals. Burden of disease, if you see 36% of the communicable diseases, where I am going to talk about the including vector-borne diseases here. Now, of course, road accident, everything is also kept here, injuries and all, they are very minor. Expenditure on health, if you see, percentage of GDP 4.6%, and per capita is 27. Number of beds per 10,000 population in India, 9, when compared to Korea, 132. And doctors per 10,007. Of course, this is official figure. If you go to any public health center or district level, that doctor will not be there. If the local conditions are, the schools are not there, if the children are not getting good education, he will quit. Officially, his name will be there. Nurses per 10,000. This is another dangerous situation, 8. Whereas in Korea it is 37. Health policies and vector-borne disease in India, if you see, this is the biomedical disease. We have strong actually heterogeneous population. If you want to do any kind of a analysis, biodiversity, both human population and plant biodiversity, India is the richest one. In another coming 10 years, if any drug is supposed to come from India, from plant sources, that is only from India. Whether you take it for the anti-inflammatory, diabetic, or any cardiovascular, if it is from the natural products, because we have got the 45,000 plant species in India. Okay. Similarly, heterogeneous population. One person is exposed and immediately he died in the Delhi population once he get the exposure to the dengue. But whereas the dengue, same thing in Assam, he is not dying. Why? There is some kind of a genotype resistant mechanism. That's why diversified population in India. 1.2 billion. Different ethnic groups, more than 5,000 ethnic groups are there in India. And endogamous tribal population, that's why there should be a relation between the chemistry and the tribal medicine. Tribal people will use some medicine to avoid this kind of a heart attack as well as the mosquito bite. When once a chemistry have a talk to the particular tribal medicine people, then he will know what kind of medicine he is using from the plant. He can isolate and identify and synthesize it. That is a linking message. The link is missing here. 1.8 lakh sub-centers are there, namesake. 23 PHC, 23,000. 4,000 community health centers, 1,600 urban health centers. Of course, this is academic, 200 medical colleges, more than 400 research institutes under CSIR, ICMR, as well as DRDO. Now, what is the mosquito-borne diseases in principle in India? These are the malaria, Japanese encephalitis, dengue, and filariasis. This is about the filariasis pathetic situation. We are losing 700 crore rupees per annum because of filariasis. Okay, Government of India is able to meet the requirement of the control operations only 11%. They are not covering the entire under NFCP, National Financial Control Program of Government of India is not taking the complete coverage of India. 11% because they are having only urbanization, but these are all confined to rural. If they ask Government of India, they say something, their mandate is like that. What our contributions from IT point of view for the past a decade story I am putting in a zip file. This is the open-ended database we have developed on this one. What is the use of this open-ended database means? By taking user ID and password from my English center, I am going to show what is English. One can easily government authentication once we take, they can use this one. After using what you are going to do, you can build a relations. That is called association relations. If house condition is like this, if socio-economic conditions are like this, if the drug is given or not like this, if these combinations are X, Y, Z like this, then definitely he will get filariasis. Then what is the use? Then for every program you can ask me, then what is its use in the real-time application? De-link that one in order to make the positive to negative. De-link in the sense this age group to this age group, if that is there, if this is the house is a hut, if it's a hut, go for the indoor residual spray. If age group is 14 to 16 years, like a pulse polio, give the diethyl carbones and drug. That means you are linking in the chain, you are detected 2 links, you have removed it. That means the number of chances of getting filariasis is coming down. From association rules of the CART, either classification and regression tree analysis developed by Salesforce system, we have used that one. From to that, it has got to the rural level. That means it is nothing but visualization and de-linking, only thing you should understand it. And basically, a medical entomologist is trying to work on the IT people and even to the mathematical biology people, how best we can combine this in order to give a capsule form for the simplest solution. This is another database we have given to the Himachal Pradesh for the malaria, because Government of India has declared all northeastern states as endemic, but rest of the northeastern states are 50% endemic, 50% non-endemic. So this we have given to the complete user-friendly report generation system Arunachal Pradesh, for which we got award for the best project award from the Minister for the Health. Recently we got another award for the E-Northeast Award. These are all the principal secretaries of IT of the state government and including Joint Secretary of Ministry of Information Technology, Delhi. For Arunachal Pradesh malaria monitoring system we have developed. If a secretary take the charge of Ministry of Health and Family Welfare, he need not ask for the joint director. With a simple clicking system, he has got the 3-tier system, high, medium and low risk zones of the Arunachal Pradesh at village level, which is difficult manually to do it. Whereas we have done it. It is GIS based, but we have not simply ported GIS the raw data into it. We have done the data mining analysis, developed into 3-tier system, ported on it so that with a single click he can elect the public health system right from nook to corner. That is the beauty of the malaria. This is another program, Japanese Encephalitis Association rules. We have developed a program called JEB-Net, Japanese Encephalitis Basis Network. Everyone knows basis network is well established in insurance sector, banking sector and all. Whereas we have developed customized, we took nearly 1.5 years for that. It is validated by ICMR in few districts. Now they have taken away to use this program to forecast the mosquito density 1 year in advance in a given area. Japanese encephalitis, we have to think from the societal point of view. 1,400 children are died in Gorakhpur within short time, because incubation period is very short. By the time you come to know that already virus is transmitted to the children, another problem is below 15 years old children are prone to this disease. If you won't identify that it is going to be transmitted, our politicians, what they did after havoc of this one, they went with helicopter for aerial spray. What is the use? Mosquito has done her job very nicely. Virus transmitted. Virus population is there in the human community. You have to go with the vaccines. That may be also true, because India only one center is their production in Himachal Pradesh, that is closed. We are depending on only UNICEF. UNICEF will give some percentage according to the quota they have got, the international regulations. That quota is not sufficient to cater the needs of 2 endemic districts of India. Then what we have to do? That I am going to tell. Now these are all the, I will tell you, JB-Net and all. This is another thing, identification of mosquito. This is most important. Based on our expertise, DRDO asked us to take up a project in Tejpur, where our border districts are there in the Myanmar, Burma, Myanmar and all, where once malaria outbreak comes, is it because of migration of people from within the India to that Tejpur, or from surrounding country they are coming here? If they are coming from the surrounding country, is it people or infected mosquito? Bioterrorism will come into the picture. If it is a bioterrorism, means you see what kind of mosquito, is it indigenous mosquito or not? You have to identify. We have developed a simple expert system based on ID3 algorithm. You see how beautiful relation between ID3 algorithm is discovered in 1985 by Premax, Stanford University statistic professor. We took his consent, sir. This is only I'm a government, this one scientist. We are going to apply only for this one. We have to take a consent from the original inventor. He said, in my entire history, you are only the person asked for the societal applications. So far, this is only applied for the banking condition. Then we took his consent and developed the program and handed over to the DRDO. Now they are using it. Time taken for identification of the species is 20 seconds with 100% accuracy. Try to identify in order to find out which is the culprit in the outbreak. That is the one. So this is about the different domain, little bit domain things are there. At genera level, species level, subspecies level, at the species level. This is for the, another thing. We have got a web air. What is this web air? Aerodynamics of mosquito. Why do you know the aerodynamics of mosquito? Once you know the length of the flyer, breadth of the flyer, mass of the flyer, area of the wing, length of the wing, you can identify, within 5 minutes you will get 32 biophysical characters of the mosquito species. So what? For everything you can ask me, so what? So once you know the 32 biophysical characters, you can easily estimate the flight range of the mosquito from one place to another place. Once you know the flight range, you can easily calculate the number of districts covered by the infected mosquito. Once you once you know the distance travelled by this particular mosquito from breeding to flying, you can easily calculate how many villages are there in between. Once you know how many villages are there, Indian average population of villages around 5,000 approximate, I'm telling, because India is a very, this one 6,34,375 villages are there. So on an average, if you take the 5,000 population per village, you can see drug administration to be done, or insecticide to be done, or larval insecticide to be done. It is up to the domain people to calculate and see if they are protected from this one. Because you know that it is a breeding is taking place, it will fly this many kilometers. That is the one. What are all the inbuilt relations between this? You can easily calculate the beat frequency. The beat frequency in the sense number of beats per second, both theoretical and as well as practical. Once you know the number of beats per second, how you will relate it actually? It will give the kinetic energy also. Energy when it is in the motion. Kinetic energy is inversely proportional to the beat frequency. That means if kinetic energy is high, beat frequency is high, kinetic energy consumption is low. Once kinetic energy consumption is low, it will become fatigue very quickly. Once it becomes fatigue very quickly, distance traveled by the individual is less. That means it will cover the number of villages is very less. That means once the beat frequency is high, it will cover only less number of villages. This is the beautiful analogy we have given, and we have supplied this program to the various international institutes, including Nairobi, Kenya. So about this program, I have already explained. There are several things: static parameters, dynamic parameters, aerodynamic parameters, all 32 biophysical characters. And this is the basic research has got the linked to the upload. Of course, this is a paper published in the conference. This is also highlighted in Nature. And we have lots of data, we have little information, we have low knowledge. Then you have to use the data mining, which is going to pick up that hidden information from the heaps of the data to bring out to the limelight. I have developed a program for the self-organizing map, a powerful data mining tool. We have taken a case study of nearly 45 villages, 10,000 individuals. So it's a case study. Now the technology has gone to the MVBDCP to introduce this system in 5 states. What is this actually? It is nothing but coherent maps. I think if any computer person will know, it is a good old, what is my entire talk essence is, we are not interested in the age of the algorithm or implementation of the algorithm. We wanted to see the suitability of the algorithm for our domain and see how it is going to be applied. Application is normal application should be there, and algorithm is not important for us. This is a coherent maps 1960 actually from Japan. It is applied for so many things, whereas I have applied for the prioritization of the control parameters. That is not there in India. That is why outbreaks are there. Now what it is? 45 villages data I have taken, and I have normalized the entire data from 0 to 1. Whatever you take, 10,250.56 or 0.5, everything will be compressed between 0 to 1. 0 is a minimum, 1 is maximum. In visualization system, 0 represented black in color, 1 represented in dark red color. Done. All the 45 villages are clustered into 3 into 3 grid system. 1 1 1 2 1 3, 2 1 2 2 2 3, 3 1 3 2 3 3. I will magnify 3 3 and 3 2 and explain how it is going to work in the field. This is the 3 2 3 3. Let me tell you first. One is a 2-dimensional cluster. One side village, another side parameters. You see here, 1 2 3 4 villages are having dark red in color microfile area rate. That means already in the 5 villages, parasite is there entered into the human body. People are unnecessarily going to these 5 villages and doing the mosquito control where it is the mosquito population is nil. Don't do it. Do it as a secondary, tertiary or quaternary. But don't do it on a priority basis. You do it the drug administration per day 3 tablets. Diethyl carbamazine. And if your village population is 5,000, 5 into 3, 45,000 tablets are enough to eradicate with a single dose treatment. Malaria gone. This is the mirror image. Here you see mosquito density is more, microfilaria rate is less. So you go to this particular village and do the mosquito control because the transmission is not taken place. Still there is a chance to arrest the transmission. So beautiful analogy this is actually, and that is why it is highlighted in the papers like Nature. So now this technology is taken up by the Gujarat as well as another 4 states of northeastern region. Of course, this is also a filaria monitoring system given to the government of Andhra Pradesh. Now this is malaria monitoring visualization system where 3 tier medium, low, high can be given on the spot. So that based on the map, one can easily go to that particular spot. This is the village level map. Wherever you happen to see the red, you can concentrate that villages rather than yellow and blue. simple, even plus 2 students also can understand. If you take this cursor here, you will get a pop-up window where you, what is the actual numericals and all, how many people are, because so that will give an impression to the public health person how much amount of drugs to be carried out for the field conditions. This is about the Japanese encephalitis in northeastern region, and you asked me how Japanese encephalitis will be forecasting this one. We have taken all the input parameters of all these things, and this basis network will be having it will give some kind of a weightage to each parameter. That weightage I will not use, because it is a data mining related thing. If I give weightage from data mining point of view, it may be wrong. That is why now the simple solution is between two variables where the arrow is generating and showing this here is depending on the another parameter where the arrow is generated. Got it? That means paddy cultivation is depending on the agriculture land as well as place. Water level is depending on the paddy cultivation, maximum temperature, minimum temperature, and also rainfall. From where the arrow is coming, that is the actual one to influence the another parameter where the arrow is going or showing. Finally, it will be a per man hour density. That means it is a WHO unit to calculate the mosquito this per man hour density. In an hour, how many mosquitoes can be caught by one person in 60 minutes? Fermentation and combinations, 2 persons by 30 minutes each, or 10 minutes per 6 members, like that. 6 members, one member will catch hold of 10 minutes, but pour it and then that is one. So per man hour density is depending on all the parameters. This is validated in Ballari district by Indian Council of Medical Research, and the technology has gone to that 1 year in advance in a given area. This is not a generalized one. This all the particular things should be given from this. This is another one is a dengue. Of course, this is a, dengue has 4 varieties, 1, 2, 3, 4, hemorrhagic fever. We have developed a dengue decision support system. Another problem with the dengue here is once a patient, 14 days. Person should be identified within 14 days and give the suitable treatment, otherwise patient will be no more. So within 14 days, time is very less. For Japanese encephalitis also incubation is 14 days. Dengue also 14 days. What we have to do here, in Indian medical system, first 5 days paracetamol and antibiotics. In another next week repetition. And by the third week repetition comes, we will be no more. What you have to do immediately, we take the 20 cubic millimeters of blood, you have got the rapid blood analyzer, 10 minutes you will get the complete parameters. And the tail parameters you feed inside, we kept some kind of an association. Person is having a headache, person's parameters are like this, hemoglobin percentage is like this, platelet count is coming in, then it is a dengue. You will get finally whether dengue is or not, diagnosis if you click it. That we have tried with the tropical, Sir Ronald Rose Tropical Institute, Hyderabad, and Nizam's Hospital, which is another famous institute with epidemiology people, and private partnership, Yashoda, they have come forward with us to work with us. It is well validated. Soon it is going to be given to the government. But government may take or may not take. Dengue is excellent money potential returns for the government hospital. How far they are going. At least in the government sector, we want to push it. Now we have started a climate change program. Yes, alert system has come. I will complete it. We have got nearly 40 meteorological towers all over India. One tower is there in Hyderabad also. 3-tier system. For every second, I can put, I want meteorology for every second or every minute or every 1 hour according to my request. It will cover nearly 25 to 30 kilometers. If I increase the, that efficiency, it may go up to more than 100 kilometers, and I will get the data. Wind speed also. Wind speed I will correlate with the aerodynamic parameters, so that I will estimate that species-wise flight train, and I can give a solution to the government. These many villages are going to be endangered villages. Please treat that. Look into it very carefully. Like that. This is a CSIR mega program. We also developed a P atlas. In the, if you simply click a state and ask for a disease, you will get a beautiful points village-wise. This is the last year statistics are like this. This year it will be like this. Some kind of a projection, E-Atlas we have developed and kept it on our environment. This is my website, iactnms.nic.in. Once you open it, I will get nearly 250 to 300 hits per day. So you may surprise people from the public health, not only public health, even from the judges, from the various courts, they use it to write to me that this is a very interesting, because community participation will reduce 30% of the diseases without government involvement. That is why community should be first of all triggered, because Triggering the government system is not a one-man show, it is a heavy bulldozing picture. At least community, some people will be there, they will have a social concern, they will see that one. It is actually a World Bank center. Later on, Ministry of Information Technology, later on Ministry of Environment and Forest they have taken. It is only one center in India, probably in the world, to disseminate the information. If any outbreak is there in India because of mosquito-borne disease, in 24 hours you can see in hot news what are the outbreak, what are the reasons, why it is like this, what are these precautions to be taken. With our domain we will put it. So this is the strength of India. Community information centers, 400 centers are there in Northeast region with 250 crore rupees. 5 to 8 years back they have established August 15th dedicated to that region. But NIC they have done wonderful job, CSC, but no content. Mic is beautiful, no singer is there to sing it. There is no domain input activity. That is a problem. Now if you put all these programs well in advance to the all community centers, convert them into the local, if it is Nagaland, put them in the Naga language and all, certainly at one day or other it will go to their brains. 1% of the 0.1% of the population they are protected because of this technology. When you convert the 0.1% to the Indian population, it will be millions. But our target should be millions. So this is the community information centers, and all you go to the website and see. IT revolution in India, we have got the Param 10,000 where we have got the official MOE with the CDAC, and also I am partner with the Param Padma where I am putting the huge amount of data on it, and this is the future Garuda grid computing. We are all having the Garuda grid computing system. We should be the partner with that. And we have got the what you call NTN is also there. National Network Knowledge is National Knowledge Network is there, and we are also having the forecasting system. But bandwidth is unlimited. Hardware is very cheap. Then what do you want? Only commitment. Only thing is commitment, nothing else. And only thing to switch over it. Otherwise, why I have to talk to them means ego it is there means nothing. No ego, only go. That is my slogan. Whatever you do, fight between man and mosquitoes in endless war. Thank you. This is my 66 years old CSIR-Indian Institute of Chemical Technology. Thank you. No. No. That is not. That is not. That is not. Virus is different. Here vector. I am talking about the mosquito is not a vector for
malaria.
Yes.
Models are different.
Models are different. Because Japanese insulins model is different. Their parties are 4. Pig is a reservoir. Mosquito is a carrier. Man is a dead-end host. And the mosquito is a carrier, vector. Whereas in malaria, mosquito is the vector, pathogen is the culprit, whereas a person,
human. What is your session? You have to develop this type of session?
It should be. But input parameters will vary. You have to study the complete mechanism and see the dynamics of the. Yeah, we are unable to see the other end of the after swimming for 10 years. Because we don't have any problem in invention, we have problem with the implementation.
Dr. Murthy, you told me that you will show us how to predict. I worked in Arunachal Pradesh some 20 years ago. So I'll be interested how they are using it, how the district administration or the district health of the DMO is using this system.
No.
Does it give them advance warning that these are the areas going to be affected?
Yes.
How they do it?
No, first we have
It has to be simple.
We have ported on this visualization system to them because they cannot understand what is forecast.
Right.
We have even, if they take cursor to that one, they have to send me data and we will customize it and send it to them. And we have given 3 periodical trainings to them, all the district malaria officers of the Arunachal Pradesh in the department. We went there and all we brought them to Hyderabad. We have had a performance.
No, I'm simply asking.
They have to take care further.
So first they have to feed information,
yes.
data,
yes.
send it to you, you analyze and
that
give
is
it
one.
to you.
Now they are in a position, and once you say the customize it, once say the diagnosis process, picture will be there. It requires only Java web server for the visualization.
So they have now capability to enter the data.
Also, because once we use the technology, we will follow up also. Then they have to take it further. But people are there now, youngsters are coming up. Earlier things means the situation is different. Because people who are about to retire, they are coming to the director level. They are not at all interested. Whoever joined the medical entomologist as a fresher, around 25, we are catching hold of them. Just we are telling them, you do it like that. Because MIS is very powerfully established in all over India. MIS is very powerfully established. Only thing is people need to know how to put it, how to get back. I know you wanted to know what is the mechanism. Definitely. Oh, thank you. Thank you.